Good evening. Welcome to our OrthoCarolina webinar series. My name is Michael Gart. I'm one of the hand surgeons here at the OrthoCarolina Hand Center. I also have an office down in Pineville. If you have any questions throughout, please feel free to post them in the comments. We'll try and get to those at the end. We will also post this talk on our social media platforms once we are finished this evening. So if you need to take a look, it'll be posted for you. So I'm going to be talking tonight on the surgical management of some common hand conditions. And they always say you should start a talk with an interesting fact. So an interesting fact for you is based upon the number of attendees, the odds are very high that at least one or more of you has one or more of these conditions that I'm going to cover tonight. Another interesting fact is most, or at least many of these things can be treated in our office under local anesthetic only without having to go to the operating room. We've got what we call the minor procedure room at our hand center, which is like a mini operating room where we can do a whole host of things under local anesthetic. So first issue I wanted to talk about is a diagnosis called trigger finger. This is an extremely common problem. It affects somewhere between 5 and 10% of the general population. There are some medical conditions that place you at increased risk for development of a trigger finger, including diabetes or inflammatory arthritis or thyroid conditions. But these are quite common in people who have no other medical conditions. These typically cause pain at the base of the finger. They can also cause stiffness and locking or catching of the finger. That's where the name is derived from, trigger finger. I like to draw for my patients, so I brought diagrams because I can't draw quickly on a live webinar. But this is essentially what a trigger finger is. There's a swollen tendon nodule that can't fit through the pulley system of the finger that it has to get through. So the finger will catch and pop as this swollen tendon slides in and out of the pulley system. So it's a size mismatch problem. We've either got to make the tendon smaller or make the pulley bigger. Steroid shots are generally first-line treatment for trigger finger. They're extremely successful. They're between about 60 and 90% successful based upon length of symptoms and any medical associated medical conditions. The shot goes into the tendon sheath down in here and can reduce the swelling so the tendon can glide smoothly. Typically, we'll try 1 or 2 injections, and if those don't work, for the minority of patients who slip through the cracks, we can also release this little pulley here, and that works about 100% of the time. It's slightly more involved, but that's one thing that we do under local anesthetic here in the office setting for the vast majority of patients. If done properly, there is no sacrifice in function of the hand or the finger. Everything functions just perfectly normally, just relieves pain and catching and clicking. It's not unsafe to do more than 2 injections, just that the literature is quite strongly suggestive that 3rd, 4th, or 5th injection is unlikely to be successful. So most will try at least 1 and often 2 injections. So that's trigger finger in a nutshell. Very common problem, probably one of the most common things that we see in clinic. I wanted to move on to some more very common conditions. These would be carpal and cubital tunnel syndrome. These are both what are called compressive neuropathies, or problems where the nerves in the upper extremity are under too much pressure, and that can cause symptoms distally, typically in the hand and the fingers. Usually compressive neuropathy starts with intermittent numbness and tingling in the fingers. That is often positional, so people will find they'll wake from sleep and have to kind of shake their hands out to regain sensation, or straighten their arms to regain sensation. That can progress to constant numbness and can further progress to constant numbness and weakness and even some atrophy or loss of strength in the hand. Carpal simply means relating to the wrist. So carpal tunnel is typically a pinched median nerve at the wrist. This will give you numbness and tingling in the median nerve distribution, which is the thumb, index, long finger, and half of the ring finger. I also brought a diagram of the carpal tunnel. So this is a cross-section of the carpal tunnel at the level of the wrist. And so this is a little bit of a busy picture, but basically there's a whole lot of stuff in a real small space right here, and one of those things is your median nerve. So carpal tunnel release essentially divides the ligament that makes the roof of the tunnel to allow the tunnel to get larger and take the pressure off of the nerve. So this is what needs to be accomplished in surgery, just releasing that ligament. There are 2 ways to get there. One is called an open release, which is an incision here in the palm. That can be done in the office under local anesthesia. The other way to do it is a small incision down in a wrist crease, and it can be released endoscopically with a camera. That's usually done in the OR, although there are some new technologies coming in the next few years that should enable us to do that, potentially in the office as well. The data is mixed with regard to outcomes, but generally the outcomes are considered to be nearly identical or very close to identical between the two. I usually tell patients it's a matter of preference. Some patients prefer to avoid anesthesia, some patients prefer to avoid being awake during surgery, and so to me they're both good options. They both work very well. Generally they both have very low complications. Somebody had written in a question about recurrence. Recurrence rates with carpal tunnel are quite low. The literature is kind of variable. It puts the number somewhere between 5 and 25%. I would say of those of us who do it, it's much closer to 5, certainly, than 25. But as long as properly diagnosed, typically success rates are very good with nerve decompression. Cubital tunnel is where there's a pinched nerve at the elbow. This will give numbness and tingling in the pinky finger and the other half of the ring finger. The ulnar nerve is what's pinched at the elbow. The ulnar nerve controls most of the strength of the hand, and so the weakness with significant cubital tunnel can be very problematic. With nerve compression, they can be diagnosed a number of ways. Typically, we will obtain what are called electrodiagnostic studies, which is a nerve test to look and see where the nerve might be pinched and how badly it's pinched. If symptoms are classic, sometimes we can proceed directly to treatment for that condition, but it's more often done through electrodiagnostic testing or nerve testing. Treatment options consist of lifestyle modifications and bracing. Steroid injections can sometimes be helpful for carpal tunnel. It isn't safe to inject the cubital tunnel, so we don't use steroid injections there. And if those don't provide sufficient relief, we typically move to surgery for nerve decompression. Post-operatively, these are rather straightforward surgeries. You usually have a soft bandage for a few days, no restrictions. A little bit of soreness in the palm that can be a variable length after carpal tunnel release, anywhere from a few days to a few weeks. Cubital tunnel is typically quite easy. It's a little bit of an irritating place to have an incision when you rest your elbow, but aside from that, it's usually a pretty straightforward recovery. Moving on to one more common, before I forget, here's my little cubital tunnel diagram. So this just shows we're essentially doing the same thing in the elbow, but we're releasing a different structure. This is called Osborne's ligament, which is the culprit that typically pinches the ulnar nerve of the elbow. Another very, very common thing that we see in the office that we get lots of questions about is arthritis in the hand. Arthritis pain in general comes from inflammation within a joint that is no longer gliding smoothly because the cartilage has worn down or worn out over time. That is the case with osteoarthritis, which is the most common type of arthritis we see. There are also some others, typically inflammatory arthritis, such as rheumatoid arthritis or lupus or psoriatic arthritis. Although we do see a fair bit of those, they're far less common than osteoarthritis. So treatment options for arthritis are typically anti-inflammatory medications. These can be oral medications, topical medications. There's some newer data that CBD oil can work quite well, in particular in the hand, as a topical treatment for arthritis. We typically use steroids, both oral and injectable steroids for arthritis. Generally speaking, if everything else has failed, surgical treatment for arthritis in the fingers typically sacrifices motion to alleviate pain. And so the best candidate for finger arthritis surgery is someone with lots of pain and very little motion, because then you stand to gain quite a bit from surgery and you don't sacrifice very much through range of motion. So if you think of the fingers in 3 joints, I kind of broke this down to make it a little bit more simplistic. So the joints at the end of the fingers are called the distal interphalangeal joints, or the DIP joints. These are very, very, very commonly involved with finger arthritis. These can lead to what people refer to as crooked fingers or knobby fingers. These can lead to large bone spurs that some people find unsightly or can be painful, and commonly can cause angulation deformity at the tip of the finger. Treatment options for kind of finger and hand joint arthritis is what's called arthrodesis or fusion, where you make 2 bones into one and you get rid of the joint. There's also something called arthroplasty, which is a joint replacement. In the DIP joints, there are no arthroplasties. They don't even exist. Arthrodesis is an excellent option, has very, very good outcomes. It does sacrifice all of the motion, and so it's typically reserved for patients with refractory pain or who have very little motion at baseline. But arthrodesis is an excellent option if everything else has failed for the DIP joints. Moving a little bit farther forward are the PIP joints, or the proximal interphalangeal joints, these joints right here. Those are tough because if you look at your own hand when you make a fist, there's about 120 degrees of motion through that joint. And so if you sacrifice that, it's very challenging to make a fist or straighten the finger. So we really try to avoid fusion at the PIP joint whenever possible. Joint replacements do exist, but they're just not great. They have a relatively high revision rate and complication rate. They are used in certain settings, but by and large, we try to avoid surgical intervention whenever possible for the PIP joints. Fusions do well, they just sacrifice a fair bit of function, and so we tend to shy away from those. So fusion, maybe, replace, maybe, not really a lot of great options for the PIP joint. The next joint down is what people commonly call the knuckle, or the metacarpophalangeal joint, or the MP joint. These are usually spared from osteoarthritis. These typically are more involved in patients with inflammatory arthritis, such as rheumatoid arthritis. Much like the PIP joints, fusions are very morbid because they do sacrifice a fair bit of function and range of motion. They work very well for pain relief, but they're often poorly tolerated. This is one area in the hand where joint replacements actually work quite well. Oddly enough, did one earlier this afternoon, but they're actually quite common, especially in patients with rheumatoid arthritis or inflammatory arthritis. It's a relatively common operation. They don't increase motion, but they're very good at alleviating discomfort. Moving on to probably the most common arthritis condition that we see in clinic, this would be thumb basilar arthritis, or what we call CMC arthritis. We call it that because it is arthritis involving your first carpometacarpal joint, or your CMC joint, which is this guy right here at the base of the thumb. So this is an example of a hand before any work has been done. Arthritis typically begins at this joint here at the base of the thumb and ultimately can progress to involve this entire bone here. This will usually manifest as pain at the base of the thumb that's worse with pinching or gripping. People will very often complain that it's difficult to open tight jars. This has a predilection for the non-dominant hand, and so you will very, very often see a right-handed person with left thumb base arthritis. That's very common. Treatment options for this are similar to other finger joint arthritis. Anti-inflammatory medications are a mainstay, steroids, oral and injectable. One difference is braces can work quite well for thumb base arthritis. CBD oil actually has the most data for CMC arthritis, and that can be good topically. Because this is an extremely common condition, we often need to treat it surgically, and so if all else fails, there's a good surgical option called a CMC arthroplasty. And so just some details of that. What's done in that operation is the trapezium bone is removed completely. That just physically removes the arthritis, and so it's an excellent operation for pain control. The data is very, very robust and essentially says as long as you take the bone out, the rest does not matter. Practice patterns vary widely across the world, to simple bony resection to implant arthroplasty or joint replacement and resurfacing. Typically what we will do, at least in this country and in most parts of the world, is some sort of what's called a suspension plasty to keep the thumb out to length so it doesn't subside and begin collapsing into the next bone in line, which is the scaphoid bone. There's various ways to do that. Two of the more popular ways of doing so are either using a tendon from the forearm or using a little prosthetic sling to keep the thumb out to length. Wonderful operation, really high success rates. The recovery can be a bit lengthy. Typically you're in a splint for 2 weeks full-time, followed by intermittent splinting for about 4 to 6 additional weeks. Most people are in therapy between 2 to 2.5 months, and so start to finish, it's about a 2.5 to 3 month course. But overall success rate's very good. Most patients are very satisfied, very happy to have gone through it. A very, very common operation that we do here. One last question, just to somebody had written in a question earlier asking, what is Dupuytren's disease? This is a little bit of a grainy image, but Dupuytren's disease is an often misunderstood diagnosis. Everyone has this normal tissue in their hand called palmar fascia, which basically runs the same course as the tendons to your fingers. That tissue can become thickened, and that's called palmar fibromatosis. That thickened tissue can then form what's called a cord that can contract and begin drawing the finger down. Dupuytren's disease is palmar fibromatosis that causes contracture in the hand. A number of different ways to treat that, probably beyond the scope of a talk like this, but somebody did ask, so I wanted to make sure that I mentioned. I'll probably stop there to take some questions. We tried to cover some of the more common things that we see in clinic. I want to first thank you guys for attending. And remind you that this will be posted later on social media if you need.
So first question we have, are surgeons still using pyrocarbon joint replacement or osteoarthritis?
I did about 3 hours ago. Yes. They're generally done for the MP joints. These guys down here, they used to make them for the PIP joints, but the complication rates were quite high, and so they're still manufactured, but you need to meet special criteria to be able to use them in the PIP joints. They're used commonly in the MP joints, but mostly for patients with osteoarthritis of the MP joints. Without getting too much into the nuance, the pyrocarbon implant needs the soft tissue structures of the joint to be unharmed, and that's usually not the case with inflammatory arthritis.
And then another question we got was, do I need surgery for trigger finger if I have arthritis in my hand?
Depends on what you've done so far for your trigger finger. Although they're both quite common, they should strictly be separate issues, the arthritis and trigger finger, although certainly plenty of people have both coexisting. You don't need to really ever treat a trigger finger unless it's painful, which it usually is. We'll occasionally see patients with painless triggering, and it's harmless as long as it's not bothersome, but it's usually a nuisance and or painful. But you should try a shot first. They usually work.
And then another question, how painful is the recovery for carpal tunnel?
How painful is the recovery for carpal tunnel? It's difficult to answer that directly because everybody kind of deals with discomfort differently. I would say I've seen people who have gone back to full activity a day after doing both sides at the same time, and I've seen people who need 2 and 3 months to return to work. On average, we typically see folks 2 weeks after surgery. I'd say on average most people are back to most things that they want to be doing by that time, and typically sooner.
And then another question we got, for trigger finger, is it better to get steroid injections sooner than later? Is it more effective if treated sooner?
Yes. So the newer data that's out there essentially says, or I guess the newest that I've seen, shorter duration of symptoms and no medical comorbidities like diabetes, thyroid disease has the highest success rate with injections. Longer duration of symptoms and presence of a medical condition that might contribute to trigger finger reduces the success. That was the 60 to 90% figure I gave you before. Short duration, no medical comorbidities is about 90% success rate.
Great. And then another question we had was what is the treatment for Dupuytren's?
What is the treatment for Dupuytren's? So, long and short of it, if the disease is primarily in the palm and it is causing a contracture of the MP joints, or these joints here, that can be treated with an injectable medication called Xiaflex, which can dissolve some of that tissue. It can be treated with what's called a needle aponeurotomy, which is where you can make small cuts in that cord to release it, or it can be treated with surgical excision of all that involved tissue. When it's primarily affecting the PIP joints, or these joints in the hand, generally surgery is the best option. The injectable medication is kind of limited use beyond the palm, and a needle aponeurotomy is not usually considered very safe to do at the level of the fingers.
And then another question was, what is your preferred treatment for Dupuytren's?
My preferred treatment for Dupuytren's, not to sound like the biased surgeon, but my preferred treatment for Dupuytren's is surgery, mostly because I think it gives the most complete correction and the recurrence rates are quite a bit lower. Usually recurrence rates are measured in 5-year recurrence of symptoms in contracture. With surgery, it's about threefold lower than with some of the non-invasive or less invasive techniques.
What is the recovery like for a wrist extensor synovectomy?
Recovery from wrist extensor synovectomy, generally speaking, it depends a little bit on why you're doing it, but typically that would be sort of maybe a splint for a week or so just to let things quiet down, and then immediate return to activity without restrictions. Probably minimal pain, minimal downtime. There's a lot of different reasons you might do it. Synovectomies, it's kind of hard to lump them together, but in general should be pretty easy.
This person's had 2 injections for trigger finger and it's back again. Should they get another injection? It's very painful and makes it hard for them to write.
So the data on trigger fingers basically says your first shot is your best, your second shot is pretty close, and third, fourth, fifth are not likely to work. And when I say work, I mean cure the problem. So the intention of a steroid shot for a trigger finger is to cure the problem, not to temporize the symptoms. So first shot has about a 60 to 90% cure rate. Second shot is slightly less than that. Third drops off pretty significantly. That said, all of the data looks at short-term recurrence. And so if you've had 2 shots and your trigger finger comes back in a year, I don't think anybody has good data with what to do at that point. It's safe to have more injections as long as they're spaced apart enough that you're not worried about weakening or harming the tendons. It's just we know they're not likely to be the final answer. So it's okay to have a third. It's just you'll likely end up asking the same question.
For SLAC surgery, what can you expect afterwards?
So the question is for SLAC wrist surgery, what can you expect afterwards? SLAC is a very broad category. Generally speaking, the 2 kinds of surgeries done are either a mid-carpal fusion of some kind or a total wrist fusion. Those are usually the 2 surgeries you're dealing with. There's some nuance there as well, but with most of the surgeries for SLAC wrist, you'd probably be looking at about 4 to 6 weeks in a cast, followed by usually some therapy for several weeks thereafter. Often, like most arthritis surgery, it'll sacrifice a little bit of wrist range of motion with the goal of alleviating pain. So I think those are all the questions we've got. Just want to thank you guys once more for attending. Look out for next month's webinar. We've got Dr. Ellison talking about hip and knee. And again, this will be posted on our social media channels later. And thanks for tuning in.